Good afternoon and welcome to United TV. It's the last Bariatric Friday of 2024. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. How are you today?
Good.
Excellent. Good to be here.
So this is our last live Bariatric Friday for this year, and we are going to cover more like an overview of what we have done, looking at the future to see what's on our way. And some of the highlights of our 2024, what we have in 2024. So now I want to start with the future of bariatric surgery in 2025, especially with the weight loss drugs and different maybe technologies out there. What is on our way for 2025 in your opinion?
Absolutely. So just looking strictly on bariatric surgery side, I think we're going to see a continuous reinforcement of the minimally invasive approaches to bariatric surgery, which is essentially the laparoscopic or robotic approach, whereby we are able to do very complex procedures through very small incisions, enhancing greatly the acceptance of the surgery itself, but also making it a lot easier for patients to recover from that surgery. As you well know, our surgery center is one of the pioneers in outpatient bariatric surgery, but I think that trend will continue as people see that it is in the appropriate preparation, a safe process. There will be more and more centers that will going to be interested in offering this, but also patients are also going to be much more proactive in wanting that kind of setup. There is really no reason for patients to stay in hospital for 2 days, 3 days after bariatric surgery in the right setting. So I think that will continue to be reinforced. Certain procedures that are in the horizon that have been done in an experimental basis but are gaining ground are something like the SADI procedure, for instance, which is a single anastomosis duodenal-ileal bypass, which is a version of the duodenals which can be done with one single anastomosis, essentially. That is still being propagated, mostly not totally accepted by insurance companies, but I think that will gain grounds as well in the near future. Another area of bariatric surgery that I think is going to be very interesting, Kemal, is the understanding, continuous understanding what procedure should be best suited for which patient, right? In other words, it's very difficult sometimes to ascribe a certain treatment to everybody in the same manner, as we are really learning more in medicine in general, like in cancer care, for instance. In cancer care, as you know, oncologists are becoming much more aware now that the same treatment may not necessarily apply to everybody. Genetic differences may have to be studied. The same approach might have to be taken for bariatric surgery as well.
So do you foresee any new procedures or new tools in that? Like, I know robotic is being used some. So this week is your turn.
It is. Excuse me. Yeah. I think, as I said, the SADI procedure is doing endoscopic sleeve gastrectomy may be the other area that will become probably more diffuse once we have enough studies, once we have improvement in the equipment. That means really undertaking a procedure similar to the sleeve gastrectomy, but with an endoscopic approach as opposed to doing the incisions.
Now, one of them is the overstitch, right? Do you think it's going to get any momentum?
The overstitch itself actually, Kemal, has not become very, very popular because the results have not been that great. It's more of a revisional procedure whereby we can go endoscopically and try to tighten the anastomosis in gastric bypass. But the same equipment is being utilized really to improve the techniques is the ability to undertake connections between the stomach and the intestine using magnets. This is very, very interesting because the surgeon essentially will allow for magnets to go inside the person's body endoscopically. Those magnets will be placed into strategic positions, and then they will come together and slowly they will create an opening in the intestine between one part of the digestive tract and another. So it is a fascinating
So there won't be any
idea.
cuts or anything.
So no cuts essentially. The magnets themselves will create by slow erosion that connection between the two portions of the digestive tract. That's still at a very experimental level, although there have been some reports of the procedure being done in humans as well. So that's another area.
Earlier, we discussed in the United TV 2 p.m. episode is the coverage problem. So do you see any changes in 2025 from the insurance companies in terms of covering bariatric surgery?
I should hope so. I should hope so. The evidence is overwhelming, Kemal, that obesity should be treated as a medical condition. And the most effective treatments should be available to patients without any problem. So certainly, I want to see us going away from situations in which bariatric treatment is carved out from plans as something that's not available to patients. And there are encouraging, obviously, signs that this is being accepted, particularly with the introduction of medical. I think the momentum is rising now of awareness that obesity is so central to many of the chronic illnesses we have in this country.
Sure.
And addressing it is actually something that we cannot shy away from.
Even like today, we had one of the patients, we had to close it because of the coverage issue.
Yeah.
And in 2024, 2025, like these times, I don't think it's time for us to still have these types of limitations on health insurance coverage.
Yeah.
If imagine like if the insurance company doesn't cover anything related to diabetes or hypertension. So morbid obesity is in the same group as a chronic illness, and then for this to be not covered by the insurance company should not be the case anymore. Now, from the patient's standpoint, are there any? Well, actually, I'm sorry. From the role from the technology standpoint, what technology plays in improving the outcomes? Are we predicting any outcome changes related to these new technologies?
So I think the new technologies, like it is happening everywhere in medicine or rather in other fields, essentially, will be enhanced, particularly with better management of data. Certainly, the job of doctors is going to be much more enhanced when we have the capability of gathering so many parameters within different things that have been gathered of patient outcomes, right? So not only will be able to have ready access to this, but we will have an ability to analyze data so much more quickly that I suspect there will be many more papers coming out, giving us better direction on how to approach many problems that currently are very difficult for us to assess. Whether that will be in 2025 or the next year, I'm not sure, but certainly the pace of progress in this area is accelerating.
I see. Now, so if we were to kind of highlight the 2024 for CHRIAS and for you as a surgeon, can you actually maybe give a couple examples of like really good outcome of what you have seen without the patient specifics, but what was the best outcome that you have seen in 2024?
So it's very difficult to pick one specific because there are so many great outcomes come on. But today I actually just saw a patient on follow-up. That patient, we first met them when they were having gallbladder issues, right? And they went to see a general surgeon in a very large health system. And they were told at that time that they couldn't have their surgery done because their weight was too high. That person's weight was 570 pounds, very high, clearly. And that is a person, obviously, who has struggled with weight for a long
Started
time.
with 78 BMI. Was that the one?
That was absolutely right. The BMI was 72. It was 72. Body mass index was 72. And rightly so, the general surgeon felt uncomfortable, and they sent them to us because we obviously deal with morbid obesity on a daily basis. And the problem with the gallbladder was not very, very acute at that time. So we were able to temporize things, but we placed that person actually on a weight loss program that we utilize before surgery, as you know. And as we were working through that, the person's gallbladder decided to act up, and we had to do the surgery. Obviously, we were forced. One of my associates actually was on duty at that time and was successful in taking care of the gallbladder problem with very small incisions, the standard laparoscopic cholecystectomy, but now on a person really with very, very high mass index. Well, of course, that was also our first acquaintance with the patient. And obviously, the weight issue we needed to address as well. And the patient was very keen on doing that as well. But obviously, they needed direction. And we worked with that patient in preparing them well to decrease their weight to appropriate levels before surgery. Long story short, I saw that patient at about their 6 months follow-up today. Their weight is down to 380 pounds. We've started from 570, and of course they feel like a million bucks in many, many ways. Their blood sugar,
what, like 160 pounds?
Close to 200 pounds, actually. Close to 200 pounds.
Yeah.
Close to 200 pounds. And their goal is to get to around 250 pounds. And they've lost more weight than they have to lose, going forward. Doing great. Exercising every day, a person who could, one of the things that sometimes we don't realize is that when your weight is 570 pounds, even simply moving, of course, tying your shoelaces, putting your socks on, taking care of yourself becomes an enormous task. It's very difficult. Now that person obviously is exercising, 5 times a week. Very, very happy, great outlook, new job.
That they have, the mental health that they have.
Absolutely. So that to me is gratifying. Obviously we are trained in order to alleviate suffering and prolong a healthy life. That's really our ultimate goal as doctors, right? And this is no better seen than in obesity medicine, obesity surgery, and bariatric surgery, because you really, as I showed you, a person who was relegated to a very small space in their life because they couldn't carry that weight and do other tasks that other people can do now is completely free from that. As I said, they had a gallbladder issue, which was taken care of. Now their weight is something that is being resolved. That's amazing. That is really gratifying. And of course, there are many challenges in our work on an everyday basis, as you know, but these are also highlights that we really feel absolutely great when we see.
That's great. So there's something for you there.
Oh, thank you. That was wonderful.
So this is what happens when they have a great team. Thank you for them supporting us.
Thank you very much. Thank you. Appreciate
now, while you are having that, I'm going to just discuss this high BMI patients. And I think that's the new not new approach, but maybe this is something that we are paying more attention in 2024. We start paying more attention instead of just, maybe pushing them to the hospital settings. We said, okay, well, these patients, even in the hospital, is risky. So we need to change our approach. And that's what we have done this year. And starting them with a different regime and asking them to follow up with their surgeons and their nutritionists more often. And this is one of the patients. I didn't know that you were going to actually use that example, but it's interesting that because I remember that person from our care conference.
Absolutely.
Because we didn't think we were going to bring that patient down to 60 before we have the surgery. So, and then we have today we have another patient started with BMI 80. And the first thing that I see our nurses saying that, oh, it's going to be a little bit high. Well, we are going to have this new approach that we have with these patients. So we'll have them come and see their providers more often. So the thing is, if there's the commitment from the patient side, the system is able to handle their challenges. And we have seen at least, I can tell you, 7 to 8 different patients that I remember who were over 68, 69 BMI, and they have done their surgeries and they're really doing good. Now, anyone that you weren't expecting that they were going to have a good outcome, but then they did actually have a great outcome for 2024. They may have started in 2023, but then resulted in 2024.
Yeah, absolutely, absolutely. So one of the challenges we have very often, Kemal, is try to really tease out what are temporary problems from some chronic problems, particularly from a mental health point of view. And I struggle with this myself when I am really addressing this, on our patients, in that all of our patients, as you know, have to have a psychological evaluation, okay?
Right.
And sometimes they may get a ding from the psychologist saying, well, this patient cannot have bariatric surgery because of these issues that need to be addressed, right? And it's very frustrating to go to the patient and tell them, okay, we cannot do your surgery because the psychologist feels that we have to address these issues. And the patient will say to you, but I have these issues because of obesity. If you just help me get rid of these, I will be fine, right? And so it's like a vicious circle sometimes. So working with patients and understanding their needs, and then obviously, excuse me, it is my turn this week.
Right. So it is your turn. The last week was pretty tough. And I still have it, by the way.
Sorry about that. So understanding this and teasing out what is really critically important and what is not is actually part of the job that we have, because we're closer to the patient. So we communicate with the psychologists, we define a path forward in terms of what would be something acceptable to all of us, and then we work with the patients. And then guess what? The patients go through that and they do fantastic. And there was actually a young lady that I do remember earlier this year that, many people were reluctant about whether she would do fine afterwards. And she surprised everybody. She's done really, really very, very well with her compliance, with exercise, with the dietary needs, and also with vitamin intake. Much, much better outlook on life. So, those are great situations as well.
So the one challenge that I have seen for overall for people to kind of understand patients and the systems, even the some of the different specialties, including primary care, how weight loss drugs being like the approach to the weight loss drugs. So a lot of people didn't have a good understanding of what we deal with. So then many people, many physicians, they thought it was going to be kind of like an alternative to what we do with bariatric surgery, but that's not the case. It actually does even help because it increases the awareness of morbid obesity, and because some people, they don't want to start with the surgery itself right away. They're not there, but then with the weight loss drugs, their understanding of morbid obesity changes. And even if they lose a little bit, it does motivate them to do better, because patients we deal with are not patients with 32, 33, 34 BMIs. Averaging is about 44 to 47 range. And that's an average. So that means there are some patients who are over 50. So this means we actually utilize weight loss drugs to help the process before the surgery, especially to bring them to the ideal level. But many patients who were not considering weight loss drugs before or weight loss surgery, with the drugs making things easier to get in, it does help.
Absolutely, absolutely. I mean, clearly, Kemal, if we could do everything that we're doing in terms of really get rid of their profession, right? If you can cure everything without surgery, we would want to do that, right? But we're not there. We're not there, right? So when people talk about, oh, it's only drugs now, no surgery, it's like saying, hey, we have chemotherapy and surgery for this cancer. And one side says, oh, we're just going to do chemotherapy, or just we're going to do surgery. It makes no sense, right? You have to be able to understand, one, what works with a particular approach, and often what works with a combined approach, there is no reason we should be shy about accepting that sometimes we need both approaches as well, because we're dealing with a chronic condition that requires a multi-pronged approach for us to get the solutions that we're looking for. So I absolutely welcome the development of medications that are powerful as something really very important for all. Still consider obesity as something that has to do with their appearance or with their personality, and not as an illness itself that is related to cardiovascular disease, to metabolic problems, to many other issues in their health. When people start looking at medication as a solution, immediately there has been a switch in their mindset as well. Now they think it's a disease because you use medication for diseases generally. That's how we would think.
Right.
So that actually is very important. And there are also going to be some patients who will succeed well with the medications, and there will be other patients on whom medications are not going to be enough. Or there will be some patients on whom medications will not work for a number of reasons. So having this approach is probably the best approach. Regardless what approach you have, though, what you said earlier on is critically important, is that we shouldn't be prescribing medications. Sometimes you may need an exercise physiologist, all this with a good coordinated approach. So you have to do this in a programmatic fashion where care coordination is really the kernel that holds everything together. In that setting, I think you will have success.
So,
in long-term success.
Like how many patients we actually diagnose first time with diabetes?
Yeah.
How many patients we first time diagnosed with hypertension, with their thyroid level, with TSH being extremely high, hematology, like with the hemoglobin being low. So many patients, when they come to us, they don't actually know what's wrong with them. They think that they just have morbid obesity, but then when we find out, okay, this patient has hemoglobin level 8 and it's not a young lady because of their personal things, then they may be able to, have those depending on the time of the blood work done. So then what do? We send that person to the hematologist.
Yeah.
So when they have like an extreme high TSH, we send them to an endocrinologist. So we are not taking the ownership of management of things that we are not specialized in. So this is that simple. So like this is more like a team approach, multi-clinical, multi-specialty approach that we have with United Medical ACO. And that's when we are able to see a better outcome anyway. So this, and just like you said with the weight loss drugs, it's the same thing with the weight loss surgery. We don't want our patients to just leave us just because they have good outcome in the 8 to 10 months. We want them to stay with us and check in with us at least once a year after the first year. So that's because things can go bad, and we don't want to be too late to find those out.
Absolutely.
So, but I think things are getting, at least from the medical community standpoint, how we are approaching to morbid obesity. I think we did a lot of work for that. And we can take a lot of credit for that. So who does like weekly shows on morbid obesity?
No, absolutely.
Like the multi-billion-dollar systems are not able to do what we are doing. And I have a bariatric surgeon every week here educating us on morbid obesity. So and that because it requires this special attention to the issue and repeating this, because the other day someone made some unpopular comment, some famous person, and it was about how people eat and how much they should eat and how much they shouldn't be eating. But he's just like, he's a TV personality. And he himself is dealing with obesity. But people publicly targeted his obesity instead of his knowledge or his skills and this and that. This is why we are also still talking about this, because no one is saying let's say someone has diabetes, and if they are giving advice to other people on diabetes, they don't come back and then tell them, hey, you have your own diabetes, deal with that. But then people do that on morbid obesity because there's still this social stigma of morbid obesity. And we believe that this is going to help by us talking about it, repeating these, bringing this again. And one of the things that actually maybe one of my highlights for 2024 was the way that I used to do the sessions on the sexual well-being for the last 3 years. Two of us were doing it, but then when we have our female surgeon, Dr. Galvin, when she came to the show, it made things a little bit more different. Not difficult, different in a way that, hey, now there is a female surgeon who can actually relate to the issues that we discuss, sexual well-being, menopause, and openly talk about these things, not necessarily the most comfortable things, but we have done those, and that was maybe one of my highlights for this year. But overall, this is something that that's hopefully helping people, and we are probably we are touching a lot of people's lives in a good way. Now, I personally see there will be a better understanding of the tools that we use in weight loss, from surgery to the weight loss drugs. Many people will also have a kind of more settled understanding of the weight loss drugs in 2025, because we probably start using them heavily in 2023 and in 2024. And as always, like in medicine, it's all about how much we try certain things and what outcomes we see. But overall, things are on a positive. That's at least what I see. Now, of course, we start our days with our case conferences on a daily basis. Every day, 10 a.m., 1 hour, we invest our time with our care coordinators, our practices. And I believe these are improving people's understanding. And when they need to reach out to the right people, we are right here. So anything you would like to add before we close for the year?
Yes, so the other issue that is interesting about obesity is that for the first time in the years between 2022 and 2023, there has been actually a plateauing in the rate of obesity, because for the past 2 decades, the rate of obesity has been accelerating in this country. For the first time, we've done actually a slight decrease even in the rate. That's very encouraging in many ways. We don't know whether that will sustain itself, but obviously we still are talking about obesity rates in the 40% range. Clearly, the rate of severe obesity is still very high, around 10%. That's BMI greater than 40. And of course, there is a disproportionately high rate of obesity among minorities, including Black African Americans and Latinos as well. So we still have a lot of work to do, but I thought that was a little bit of glimmer of hope, really, when I saw those survey results about the rates of obesity. So something to really hope for. Whether it will be sustained or not, we will see. But that's just a little bit of good news.
Right.
Yeah.
Well, again, thank you for joining us. Hopefully today's session was insightful and inspiring for those who are looking for help. And we try to reflect what happened in 2024 and look ahead and see what the future of bariatric surgery is. We'll be back in
2 weeks.
3 weeks.
Okay, 3 weeks. Yes.
No, 2 weeks.
2 weeks. 2 weeks.
We're missing on the next week. So we'll be back on January 10th.
Yes. Yes.
So next week there will be a premiere running, but we'll be live with the new cycle of Bariatric Friday in 2025. So we are wishing everyone a happy new year, and we'll see you next year.
Thank you. Happy New Year.
Thank you.
Thank you, Kemal.
Bye-bye.